Hello everyone and good afternoon. Welcome to this December edition of the LVS Journal Club. I'm Sivert and I am the medicine consultant at LVS, and we are going to have a pancreas themed today's journal club. So the first paper we're going to tackle is this paper from Israel in collaboration with the GI lab at Texas A&M. Protease inhibitors, inflammatory markers, and their association with outcome in dogs with naturally occurring acute pancreatitis. Common disease seen in dogs. Acute pancreatitis can present itself anywhere from a very mild inflammation to severe disease that can trigger both local and systemic complications, including acute kidney injury, systemic inflammatory response syndrome, pulmonary failure, pleural effusion, and CNS signs. And mortality has been reported between 27 and 58%, which is quite high. Clinical signs naturally would vary depending on the severity of the disease, but common signs associated with acute pancreatitis is vomiting, seen in more than 90% of cases, abdominal pain, which is seen in about 50% of cases, lethargy and dehydration. Occasionally fever and diarrhea as well would be seen, and that's seen in about 30% of cases. Naturally, the complications, if there are any, would also cause its own set of clinical signs. For example, an acute kidney injury can make the patient oliguria or anuric. Pulmonary failure or SIRS or pleural effusion will make your respiration rate go up. You could become tachycardic, or the patient become tachycardic. And the pancreatic encephalopathy has been reported, causing neurological signs. The pathogenesis of acute pancreatitis is generally thought of as caused by intra-acinar or trypsinogen activation to trypsin. Trypsin activates proteinases and lipases within the pancreas, which then leads to tissue damage, necrosis, and inflammation. This inflammatory response is complex, again depending on the severity of the disease, but also could be dependent on local and systemic factors, for example volume, status, and perfusion. Regardless, increases in cytokine response and excretion is seen, especially of pro-inflammatory cytokines and interleukins, such as interleukin 1b, IL-2, and IL-6. TNF-alpha and CRP increase is also commonly seen as a response to especially interleukin 6 secretion. Depending on the degree of cytokine release, SIRS and MODS, multi-organ dysfunction syndrome, can develop. In human medicine, cytokine concentrations actually correlate with severity and prognosis. However, this has not been shown in dogs, where TNF-alpha concentrations, IL-1 beta, IL-6, IL-10, and IL-18 all have been investigated and failed to show a significant correlation with severity. One of the things that it might be worth noting, which was also noted in the introduction by these authors, is that the activation of trypsin is currently being questioned as the sole cause of acute pancreatitis, as there is some evidence coming out of experimental studies showing that sertraline and cathepsin B also might be playing an important role in acute pancreatitis. Now, the pancreas is generally very good at looking after itself, and such it does have defense mechanisms, and it's only when these are overwhelmed that the enzymatic change and inflammation occurs. Some previous research have therefore assessed proteinase inhibitor levels in dogs, especially alpha-1 proteinase inhibitor, which was previously known as alpha-1 antitrypsin. And studies have actually shown that some of these, or at least the alpha proteinase inhibitor, was increased or normal in dogs with acute pancreatitis, suggesting that the pancreas is trying somewhat to potentially try to protect itself, or the body is trying to produce more to protect itself. And antithrombin has been shown to be reduced. So the Aim of this study was then to characterize concentration of proteinase inhibitors and pro-inflammatory cytokines in canine cases of acute pancreatitis versus healthy controls. They diagnosed pancreatitis based on either increase in DGGR lipase of more than 250 units per liter or amylase activity of more than 4,500 units per liter. So one of those had to be combined with two or more ultrasonographical findings consistent with acute pancreatitis, such as pancreatomegaly, pancreatic hypoechogenicity, peripancreatic hyperechoic mesentery, and presence of peripancreatic fluid. In addition, these two or more ultrasonographical findings had to be combined with a CPLI of more than 400 micrograms per liter at presentation or on the following day. Patients that were put to sleep within 24 hours for financial reasons were excluded, and dogs with chronic underlying diseases were also excluded. Blood was taken on presentation and 24 hours after presentation and stored for analysis. And the patients were also scored in 3 different clinical scoring systems. Non-survivors were characterized as death within 30 days of diagnosis. The scoring system that I'm going to bring forward and that I'm showing you right now is called the Canine Acute Pancreatitis Score, or the SCAPS score. This is a score that was developed and validated by a French team in 2019, and is basically a point allocation system which showed that a SCAPS score more than 11 was associated with poor outcome. They've also, because SIRS can be quite difficult and takes a lot of time to figure out, they also made a simple SCAPS score, which is simplified in the sense that instead of doing assessing whether the patient has SIRS, you only need a respiration rate. When it comes to coagulation disorders, what that means is that is defined by the presence of at least one of the following criteria, so either thrombocytopenia with a platelet count less than 63, PT or APTT prolonged more than 25% of the upper end of the reference interval, or a combination of the two. Both of these scores, they performed well in the study by the French group, and this study uses the CAPS and the SCAPS in addition to an organ point allocating system that is quite massive from Australia, which I'm not going to bring up for you guys to see, but based, and also because it wasn't significantly associated with outcome in this paper, I didn't feel it was need to bring it up, but please contact me if you want the link to the paper where it's described. The sensitivity and specificity reported for the use of CAPS is 86 and 92%, and for simple CAPS, sensitivity was 100 and specificity was a little bit worse or poorer of 85%. Then over to the results from the current study. 31 dogs with acute pancreatitis were included and 51 healthy controls. Mortality rate was a little bit lower than from previous studies of only 19%. The death happened within 3 to 14 days from presentation with a median of 5 days. Median age was 9 years, and 58% of the acute pancreatitis groups were male dogs. They also showed that time to presentation from onset of clinical signs were on average 3 days, but the earlier presentation to the hospital, the shorter the hospital stay was shown. Time to presentation from onset of clinical signs to it was not associated with outcome. From a diagnostic point of view, they saw that the CPLI and the GGR lipase were moderately positively correlated, but neither were associated with outcome. However, they did see that the CPLI was higher in the non-survivor group compared to the survivor group, but that was not statistically significant. Then looking at proteinase inhibitors and cytokines, antithrombin activity was lower in acute pancreatitis on day 1. Day 0 and day 1 CRP, TNF-alpha and IL-6 were higher in acute pancreatitis, but alpha-1 proteinase inhibitor concentration was not different between the groups, as neither were IL-8, IL-2 and alpha-2 macroglobulins. When I looked at survival analysis in cytokines, hypoantithrombemia on day 0 and day 1 was associated with death. IL-6, TNF-alpha and CRP were not associated with non-survival, and the hemostatic measures were also not significant. So if the patients were bleeding, that was also not significantly associated with death as outcome. Then they ended up looking at survival analysis and clinical scores, and like I said, they used 3 clinical scoring systems where only CAPS were significantly associated with outcome. CAPS and simple CAPS are strongly correlated, but actually and CAPS and organ score clinical scoring index were weakly correlated, but only CAPS were significant, or the score were significant associated with outcome. Higher CAPS score also was associated with a lower antithrombin as well, which again was associated with death, and higher CAPS score also associated with higher day 0 and day 1 CPLI, CRP and IL-6. When it comes to complications, so they saw that they were not correlated with death, and the complications seen in this study was DIC, severe thrombocytopenia, suspected hypercoagulability, AKI, SIRS was actually seen in 77% of dogs, and also quite a few, 5 dogs I think had DKA, and none of these complications were associated with death. So in the discussion also, a little bit kind of thoughts from this study is from a clinical point of view. I think CAPS might be something that would be interesting to try to use as far as it's possible to use in the clinic. It could potentially be a way to prognosticate and also to talk to owners and let them know that the animal is more likely to die if they have a higher CAPS score. Interestingly, antithrombin being low also could be either a target for treatment, especially potentially in severe cases, as it was associated with death. And this is also reflected in people, and also, in rats and mice, where it's shown that treatment with antithrombin could prevent development of acute pancreatitis. However, treatment with fresh frozen plasma is not associated with better outcome in people, and in a retrospective paper, it was associated with death in dogs. That probably could be related to that the more severe cases with acute pancreatitis received fresh frozen plasma, so might not be entirely correct, but something to kind of keep an eye out for, and also whether we can start measuring it and using it as a prognostic factor, and combining antithrombin and CAPS as well. CPLI was not associated with outcome in this paper, but we saw that CPLI was higher in the non-survival group compared to the surviving group. So also something that might be interesting going forward with further studies, and also use of CRP or use of even antithrombin as a zero measurement to see whether the treatment is working or the patient is going in the right direction. So that was that study. We're then going to go over to the second study, which is the next study is the evaluation of asymmetric dimethylarginine as inflammatory and prognostic marker in dogs with acute pancreatitis from this Italian group. And basically, the inflammatory response that we talked about as a part of the introduction in the previous study is also causes release of reactive oxygen species and reactive nitrogen species as a part of the inflammatory response, rather than just inflammatory interleukins and cytokines and proteinase inhibitors, and nitric oxide, which is a reactive nitrogen species, is inhibited by asymmetric dimethylarginine, which is then upregulated in as a counterbalance to the inflammation in tissues. You are rightly thinking that ADMA sounds very much like SDMA, and SDMA and ADMA are both methylated derivatives of L-arginine, an amino acid that are generated from proteins. SDMA is almost completely eliminated by the kidneys, and therefore it can be used as a marker of kidney function, whilst ADMA is also degraded by an enzyme, and therefore is generally not as good a marker for renal function compared to SDMA. In this paper, their hypothesis was that they thought that ADMA would be a useful indicator of reactive nitrogen species, and also nitrogen oxide synthase balance, inflammation, and survival in dogs with acute pancreatitis. They collected blood prospectively. This was analysed a while after the collection because it was a part of a different study, and their inclusion of cases and diagnosis of pancreatitis is very similar to the previous study, where they needed to have clinical signs, 2 or more, typical of acute pancreatitis, changes with acute pancreatitis on ultrasound, however, instead of a quantitative CPLI, they were happy enough with a SNAP CPLI, so a positive SNAP CPLI to include the patient into the acute pancreatitis group. They enrolled 44 dogs in the acute pancreatitis group and 28 in the control group. They found that the mean age of the acute pancreatitis group were 10.4 years, which is similar to the previous study where the mean age was 9. Variety of dog breeds, but poodle was the most common. Males, were consisted, or 54% of the acute pancreatitis group were males. SCAPS again was performed, and the median was 8, and in this study actually mortality was 31.5%, which is similar to what was previously reported. In the results, they found that ADMA was higher in the acute pancreatitis of 62 micrograms per deciliter versus 48.6 micrograms per deciliter in the control group. As you can see in the figure to the right, is it's shown the 2 groups, and it's a significant amount of overlap. So that's definitely something to be mindful of. They also saw that ADMA was higher if CAPS were more than 11, consistent with more severe disease based on the CAPS score. Mortality was analysed, and in univariate analysis they found that CAPS score more than 11 was associated with mortality, similar to the previous study. CPR and T0 ADMA, so on presentation, were also associated. However, after binary logistic regression analysis, only ADMA was significantly associated with mortality. So the discussion, they talk about association between high serum ADMA and death in canine acute pancreatitis. They saw that some of the cases where they ended up seeing them back as re-exams, they also had blood from those times, and they analysed it and showed that the ADMA was decreasing in the surviving dogs. So they're wondering whether there could be some use for longitudinal monitoring, and also whether I think also it could be an interesting thought whether there is any relation to chronic pancreatitis from that point of view. So potentially another prognostic marker for cases in ADMA, so whether there's something that we can come up with a panel of prognostic indicators for patients with acute pancreatitis, where you include antithrombin as well, potentially. Then the third study, we are going to go on to a complication which can be seen by pancreatitis, which is bile duct obstruction associated with pancreatitis, and this was seen in 46 dogs. So it's a retrospective review where they, in the introduction, say that pancreatitis was reported to be a very common cause of extrahepatic bile duct obstruction in a paper from 1995, where 42% of cases of EHBDO had pancreatitis-associated biliary duct obstruction. The EHBDO in itself can cause a lot of significant changes and physiological derangements, such as changes in hemostasis, hepatic injury, alterations in hepatic circulation, reduced reticular endothelial activity and therefore your immune system, gallbladder necrosis and rupture. And what part of their aim was to look at the development and also the treatment of these patients from presentation to either mortality, to death, or to discharge, and they wanted to look at the differences between treatment of pancreatitis-associated BDO. And there's typically two types of treatment: medical or surgical. Medical will be supportive care and giving them enough time for the irritation and the swelling and the cause of the obstruction to ease down, while surgical decompression is typically associated with either placing a stent into the common bile duct or to cholecystoduodenostomy. However, case fatality associated with more aggressive surgery has been reported up to 50%, so it's a significant risk of doing biliary surgery in association with pancreatitis. Material and methods in this paper, like I said, it was a retrospective medical review of medical records. They diagnosed pancreatitis by using this pancreatitis scoring system, where 1 point per clinical finding or by chemical abnormalities or abdominal ultrasound abnormalities, and depending on the degree of abdominal ultrasound abnormalities, they were given 2 or 3 points. But if more than 10, that was consistent with pancreatitis. Diagnosis of biliary duct obstruction was total bilirubin more than 35 micromoles per liter, and common bile duct dilation of more than 3 millimeters. They took found 5 time points for data collection to describe clinical course of the illness, and T0 was the onset of clinical signs. T1 was presentation to MVet, typically 2 days after onset of clinical signs. T2 was initial documented increase in serum bilirubin, and that was on average 7 days after initial clinical signs. T3 was ultrasonographic diagnosis of PA-BDO, and that was about 8 days after clinical signs. T4 was the highest recorded bilirubin, which typically was 9 days after onset of clinical signs. T5 was initial decline of serum bilirubin by at least 17 micromoles, and that was on average about 15 days after onset of clinical signs. 46 dogs were included in the study. 24 was female and 22 male. Minter, Schnauzer, and Yorkie were the most common breeds, with 4 and 3 dogs included respectively. The median age was 9 years, very similar to the previous 2 studies, where 9 and 10.5 years were the mean and median age. Concurrent diseases were also reported in this paper, where 5 had diabetes, 5 had a cardiac arrhythmia, renal failure were noted in 3, epilepsy in 3, and thyroid carcinoma and a portal vein thrombus 1 each. And I think that just wanted to include this table as well, because I think it's quite interesting when you look at the time 1, 2, 3, 4, and 5, consistent with time on presentation to vet, time of diagnosis with increase in bilirubin, ultrasound diagnosis, decrease in bilirubin. I think on presentation or presentation to vet, we can see, similar to what has been reported before, where anorexia and vomiting are the absolutely the most common clinical signs, and about only 30% or a third of patients had fever and diarrhea. Abdominal pain only seen in about 50% of cases, so we can't rule out pancreatitis or biliary obstruction if a patient isn't obviously painful in his abdomen. Then they report what happened. So in 4 patients had actually bile duct decompression. 1 had surgery, unfortunately developed acute kidney injury and cardiopulmonary arrest postoperatively. 3 dogs had cholecystocentesis, similar to the picture I'm trying to illustrate, a needle going into the gallbladder, and 1 out of those 3 actually developed bile peritonitis and was put to sleep. When they looked at survival, all in all, 21% mortality, 9 died, and of those that died, 7 had medical management, and actually because two of the dogs that died were described above. Median white blood cell and urea were higher in non-survivors, and albumin was lower at time 0.1. ALT was higher in survivors, and albumin was lower in non-survivors at time 0.4 as well. It's quite a reasonably good outcome with 79% survival, and of the surviving dogs, 94% were not treated with biliary decompression. And interestingly enough, in people, most of these cases will not be treated surgically unless it becomes chronic. So they typically need to be icteric for about a month before any surgical decompression is performed. There were no differences between the groups when it came to dilation of the common bile duct, and the albumin at time 0.1 was 24 in the non-surviving group versus 29 in the surviving group. From a clinical development point of view, peak bilirubin was after 9 days, and decrease was seen after 15 days. Many of the clinical signs associated with pancreatitis had produced by the time of reduction in total bilirubin, similar to what we saw in the table previously shown. And then that raises the question whether this is kind of mainly these clinical signs that we see are actually due to acute pancreatitis rather than the biliary obstruction. And there's also discussion whether some of whether these patients that have this biliary obstruction, whether they have a component of chronic pancreatitis versus acute pancreatitis, because 35% of them had nodular components on ultrasound, which had been previously reported that some dogs with chronic pancreatitis and extrahepatic biliary obstruction were associated with firm mass like fibrotic areas of the pancreas, which then potentially can work as cause the blockage. And then the last thing I think this paper brings up is whether those surgical approaches, if there's any point at all. And like I said, in humans, they will only do surgery if icterus persists more than 1 month, or if it's secondary to chronic pancreatitis and they think that the chronic fibrotic issues are going to hinder improvement of the blockage. I think it's a very interesting point, and also this paper raises the possibility or telling us that medical management is definitely successful, so probably would be the first port of call. Then the last and final paper is a paper from Germany, where they looked at histopathological findings in canine pancreatic lipase immunoreactivity in normal dogs and in dogs with inflammatory and neoplastic diseases of the pancreas. This is a study where they discussed quite a bit in the introduction about diagnosis of pancreatic pathology, where they talk a little bit about DGGR lipase and that it performs similarly to CPLI, and similar to what was shown in the first study, it has a moderate correlation. Also, they say that CPLI has a sensitivity from 21 to 90.9% depending on the study, and specificity of 74 to 100%, and typically the specificity 74 to 100%, and also the specificity increases typically if you use the cutoff of 400 rather than 200. However, it does make this test less sensitive. Histopathology is considered gold standard for diagnosis of acute pancreatitis. However, it's not very commonly performed, and cytology is on occasion performed, especially if one is concerned for pancreatic neoplasia. So the aim of this study was to do characterized the biopsy submissions to Loboclin that was performed at the same time or in correlation in the patient where CPLI was also measured. So material methods, they had 1,034 pancreatic specimens from collected between 2012 and 2019, and 72 of these cases also had CPLI measured at the same time. 54% were collected at XLAP and 18% were collected at postmortem. The biopsies were assessed by a pathologist, but then reviewed by a second blinded pathologist, and were divided into 4 groups, which 1 was normal pancreas, 2 was mild pancreatitis, 3 was moderate or severe pancreatitis, and 4 was pancreatic neoplasms. The CPLI that was performed was actually a CPLI that was developed by Loboclin, and it was correlated with the Texas A&M essay, and they have just a little bit on the different scales. So less than 180 was not consistent with pancreatitis, 180 to 310 was questionable, more than 310 was consistent with pancreatitis. Then the results, so like I said, they found 72 cases. Again, median age was 9 years, slightly more males than females again, and Labrador Retrievers and Terrier breeds were the most common breeds in this paper. Histology, they found that 40 of the cases were normal, 8 had mild pancreatitis, 12 had moderate to severe, and 12 had primary or secondary epithelial neoplasms of the pancreas. Then we're going to start with the first group, which is the normal pancreas group. They had clinical signs as the prior to biopsy collection, where vomiting, diarrhea, painful enlarged abdomen were the most common signs, but weight loss, jaundice, increased liver enzymes, or neurological signs were also seen. They also asked the clinicians about the suspected diagnosis, and this was the diagnosis prior to XLAP for sampling of multiple organs. So most of these cases where they had an XLAP of where they found this normal pancreas, almost all of them had sampling of normal organs. So 25 of 40 had a suspected diagnosis of gastroenteritis. 8 had a suspicion of abdominal neoplasm, 4 had hepatic disease, and 5 were other. Final diagnosis was 19 had just gastroenteritis, 6 had abdominal neoplasms, 11 had liver disease, peritonitis, and 2 intoxication. I'm not sure why those 2 patients had peritonitis. Intoxication on one and gallbladder mucus on one. Quantitative CPLI had a specificity of 92%, where one of the other unsuspected diagnosis were consistent with pancreatitis. Then in the second group, which is mild pancreatitis group, there were 8 patients in this group. Clinical signs were vomiting, diarrhea, painful or enlarged abdomen, and weight loss. And again, suspected diagnosis prior to biopsies were 3 suspected gastroenteritis, neoplasms in the abdomen, hepatic disease, pancreatic disease, and peritonitis. Final diagnosis actually was liver disease in the majority, trauma and foreign body related peritonitis in 2, and neoplasm in 1. Quantitative CPLI had a sensitivity of 75 and at 180 micrograms per liter, and only 62.5 at 310, which is kind of similar to how the IDEX quantitative or the Texas A&M quantitative CPLI performs. Group 3 showed the group 3 of moderate or severe pancreatitis had 12 cases. Clinical signs seen were vomiting, diarrhea, painful enlarged abdomen, again, jaundice and lethargy. The majority of patients actually were suspected to have a cancerous disease. 5 had suspected pancreatitis, 2 liver disease, and 2 intoxication. They found pancreatitis in 11 of the cases, and pancreatic atrophy from chronic pancreatitis was seen in 1. Sensitivity in this was 90% at 180 and less at 310. And remember, sensitivity is the test's ability to find true positives. So it's a fairly okay test, performing at 90%. Then the last group is the group of pancreatic neoplasms, where they had 12 patients. Clinical signs very similar to before, but in addition you had 1 patient with anemia and 1 with hematuria. The main suspicion was neoplasms, and the final diagnosis was 5 had acinar carcinomas, and 4 had pancreatic mets from other carcinomas. And the interesting finding in this paper is that all of the acinar carcinomas had an increase in CPLI, which is something that is not something that has been described in literature before, where some of the pancreatic carcinomas can pretend, or they look like they are pancreatitis that is just not improving. Again, sensitivity shouldn't be there for this. So sorry, that's a typo. But when you look at the CPLI results, you can see that both mild pancreatitis, moderate to severe pancreatitis, and neoplastic cause for the increase in CPLI, they're all significantly different to the normal pancreas, or to the group 1, which is reassuring in the sense that if it's increased, it's likely high likelihood that this is actually an abnormal pancreas. However, and we can't fully rule out, for example, pancreatic cancer as the cause of the increase in CPLI. So I hope that this journal club hasn't been too boring. We've kind of hopefully touched in on some of the issues that we have with both diagnosing and prognosticating in the clinic. I think one of the things that I would highlight and also would think about when I read these papers to see how stringent they are with their inclusion criteria into what is pancreatitis and what is not, especially in the clinical papers, not this last one with histopathology. But a combination of an increase in a quantitative CPLI of some sort, in addition to, for example, ultrasound findings and clinical signs, is typically needed, because pancreatitis is a really tricky disease or it can be a really tricky disease to diagnose prior to or ante-mortem is probably a better way to say. The other thing I think is useful to highlight is to remember that quite a lot of these patients are can be quite ill, and mortality in proper acute pancreatitis cases can be quite high, and quite intensive care might be needed. So I'm open for any questions. If you don't want to throw yourself out there, then feel free to also email us at lvs@londonvetspecialist.vet for the attention of internal medicine or journal club, and I or one of my colleagues will be able to answer you. Thank you so much.